Please welcome.
Thank you. These are my disclosures. What I'd like to do over the next 20 minutes or so is to talk about the differential diagnosis of renal tumors, but also kind of talk in the context of why it's important. So as you all may know, that incidence of kidney cancer is rising. And it's rising partly because of imaging. These patients, it's my disclosures. So the incidence of kidney cancer is rising in part because we do imaging, where images patients for different reasons. So you detect them incidentally. So 80% of renal masses are now detected incidentally for the imaging than for something else. And then less than 4 centimeter masses, the so-called small renal cell cancer, are actually what we diagnose the most today. So if you think about the stage of migration, 20 years ago, we used to detect kidney cancers that were 4 centimeter and larger, whereas today, almost all kidney cancers that you detect incidentally are these small tumors. And these small tumors, 95% of them, do not result in metastasis or death. So this is a study that was done at our institution by one of our urologists, and what it tells you is that this was in patients who actually where surgical risk was high enough that they didn't want to operate on them. And so they looked at the surveillance versus patient who underwent surgery. And what you see at the 10-year mark is that the difference in survival curve, proportion of survival, cancer-free survival, is actually incredibly small between those that were treated with surveillance, so they were not operated on, versus those that are treated with surgery. What that tells you is that those small % of kidney cancers are lethal. We want to be able to diagnose them and treat them, whereas this other large number of kidney cancers that we're detecting are actually not going to kill the patient. So this is a patient who actually had CTA done from the emergency room, and we find this small 1 centimeter tumor. This is how we're detecting these small renal masses. So my outline for this talk and my goal of imaging is to actually characterize these lesions. Are they cystic or solid? Once I know if they're solid, then my goal is it a tumor or not a tumor? Is it a pseudotumor or a tumor? If it's a tumor, then the next question I want to answer is it a benign tumor or a malignant tumor? Is it a lipid-poor angiomyolipoma or an angiomyolipoma, or is it a renal cell cancer? Once I do that, the next question I want to answer is it an indolent tumor or aggressive tumor? And if I can do this really well, then the surgery would be reserved for only those patients who have aggressive malignant tumor. And that's kind of the goal of imaging. Some of it is what we do today well, and some which would be over the next few years. I'll start by talking about the modalities. So the common modalities that we use is ultrasound, CT, and MRI. PET is not commonly used in imaging of these patients because FDG is renally excreted. And so as a result, it's difficult to detect a tumor in the background of high activity on PET. I'll focus mostly on CT and MRI. Ultrasound, on the other hand, is a really great test for detecting cyst versus solid lesion. So it's low cost, no radiation or contrast for initial screening. It's great for detecting solid versus cystic lesions. So you see this echogenic kidney in this 80-year-old with a cyst in the lower pole of the right kidney. The disadvantage of ultrasound is that it's user-dependent. At least in the United States, we, as a radiologist, don't scan our patients. Techs scan the patients, and we actually are not always present in the room, so it's user-dependent on quality of your techs. And as a result, studies have shown that it has a lower sensitivity for small, less than 2 centimeter lesions. CT, on the other hand, is the most widely and commonly used modality. It's been validated in numerous studies. The disadvantage of CT, on the other hand, is that it requires isolated contrast, and there's radiation dose, and it's limited for characterizing some types of renal lesions that we'll briefly talk about. It's the same case that I showed earlier. Again, this is a imaging and nephrographic phase, and you see a cyst in the right and left kidney. When it comes to CT protocol, so if you're talking about characterizing renal masses, we routinely do pre- and post-contrast imaging. The post-contrast imaging is done in nephrographic phase of enhancement. There have been a number of studies that have shown that if you do it in a corticomedullary phase, you can miss small cortical tumors, because small cortical tumors like clear cell cancer enhance similar to the cortex. So you have to do this in nephrographic phase. Other thing to keep in mind is that the reason why we do this, right, is to actually look for two things. Look for fat and enhancement. So the pre-contrast imaging would tell you if the lesion contains bulk fat or not, and the post-contrast imaging to compare pre and post contrast to look for enhancement. If the change in attenuation value from pre to post contrast is 20 Hounsfield unit or more, you could be pretty confident that's true enhancement. If it's less than 10 Hounsfield unit, that's no enhancement. The issue lies when the change in attenuation from pre to post contrast is between 10 and 20 Hounsfield unit. As we use with novel, with recent changes in the scanner designs, it used to be, historically, was that any change over 10 Hounsfield unit was enhancement. But we know there's more pseudo-enhancement now with some of our scanners, and between 10 to 20 Hounsfield unit, you can't be confident if it's enhancement or not. And we consider those lesions to be indeterminate lesions. And again, we reserve corticomedullary and urographic phase for preoperative planning, but we don't routinely use it to characterize our renal masses. There are a couple of limitations of CT that we should keep in mind. Sometimes assessment of enhancement is difficult in small lesions, in calcified lesions, and in lesions with low level of enhancement, the one I told you about with attenuation change between 10 and 20 Hounsfield unit. It's actually important to look at that because papillary subtype of kidney cancer, which has low level of enhancement, may have change in attenuation value in that 10 to 20 range that I was telling you about. Let's look at some examples. So in this left kidney, there are two lesions, anterior and posterior, both are sub-centimeter and small. On a subtracted MR, the anterior lesion had no enhancement, the posterior lesion has this low level enhancement, and this lesion grew over time, and it was a papillary subtype of kidney cancer. I like this example a lot because this imaging is from 2004 from Dr. Bosnia and Gary Israel, where this calcified lesion, there is no way of knowing if there's underlying enhancement in this wall. But if you look on this is a 15-year-old MR, subtraction images, you see that there is an enhancement in the anterior wall and also in the posterior wall. So this was a cystic renal cell cancer. Hyperdense lesion, as I mentioned earlier, so on a post-contrast, this lesion measures between 20 and 25 Hounsfield unit. If you look at a T1 pre-contrast image and a subtraction image, you see that this has some blood product, but also has low level of enhancement. And so this lesions that is this low level of enhancement, MRI has a better contrast resolution, and you're better able to depict this enhancement. Again, this is a T1 pre-contrast image. There is a T1 bright nodule in this lesion that on a post-contrast image, the question here is this lesion enhancing? Is there enhancement in this T1 hyperintense nodule? So there are two ways to think about it. If you're going to use a quantitative parameter, that is, if you're going to put a region of interest and look for change in signal intensity from pre to post-contrast image, studies have shown that if the signal intensity changes by 15% or more, that's true enhancement. The one thing to keep in mind is that you can only do that if your pre and post-contrast acquisition parameters are identical. Because if you change your acquisition parameters, they affect signal intensity, right? So signal intensity in MRI is not based on any physical properties. It's based on your acquisition parameters. So if your pre and post-contrast imaging has different acquisition parameters, you change your flip angle, your bandwidth, your echo time, it will affect your signal intensity. And so you want to be able to actually use the same acquisition scheme for pre and post-contrast imaging to assess for enhancement. Or you can do subtraction imaging where you subtract pre-contrast from post-contrast. And what that tells you is that anytime you have a high signal, it's because of signal from gadolinium. And so this is a lesion that has a high signal, and this is enhancing lesion. This was a cystic renal cell cancer. Again, just for brief review, the cystic renal lesions are characterized by Bosnia classification. That is both a imaging, but also a management system. So we know that the category 1 and 2 are benign, 2F we follow those lesions, category 3 and 4 might be surgical. There is a new update on a Bosnia classification. This was just published this year in radiology. I think it's important to just, when you get a chance to look at it, because there are a few changes to Bosnia classification system that's proposed in this paper. And the idea here is that we're using more and more MRI to image these patients. And on MRI, because of higher contrast resolution, we tend to upgrade these lesions. The 2F look like 3, and 2 look like 2F. And so you have to be careful. You don't want to send these patients to surgery. So you want to be able to recalibrate of what we call Bosniak 3 and 4 on MR. And another goal for this paper was to actually think about some of these criteria that we use that are not as well defined, right? So Bosniak was at NYU. I had the honor working with him for a lot of years, but the way he did it was, his first paper in radiology on Bosniak classification system was how I do it. And it was a very subjective assessment of what he called thin septa or thick septa, thick calcification or thin calcification. those are not as well defined in the first paper. And so the goal of this paper was to kind of improve inter-reader agreement in Bosnia classification. But one thing to keep in mind is these cystic renal cell cancers are indolent. Even those that are CysticRCC, the renal cell cancer, they tend to be low grade, low stage, and do not metastasize. So you don't want to send these patients to surgery by overcalling these patients. So step 2, so once I know it's a solid lesion, then the goal is to figure out if it's actually a tumor or not a tumor. So this is a patient who had a fever and a white count, and you see a lesion in the left kidney. Not only this lesion has little vague margins here, there's also perinephric stranding, and there's thickening of the fascia there. This was actually an abscess. And you want to be careful of not sending these patients to OR. The history is very helpful, and you want to be able to appropriately diagnose these pseudolesions or non-tumorous lesions. The next question that I want to answer is the lesion benign or malignant? The two benign solid tumors that occur quite often in small renal masses, those are angiomyolipoma and oncocytoma. The surgical series have shown that in small tumors, 1 to 2 centimeter tumors, up to 20% or 30% in a surgical series with these benign lesions. These patients didn't need to be operated on. And the reason they got operated is because we couldn't classify them accurately on a preoperative imaging as an AML or oncocytoma. So this is a patient who has a small left renal lesion, and looks like there might be some fat in there. If you look at the pre-contrast imaging, you can see a bulk fat within this lesion, and this lesion is a angiomyolipoma. Once you detect the bulk fat in a lesion, you can confidently make a diagnosis of angiomyolipoma, and you can leave this patient alone. On MRI, there are a couple of ways to look for fat. You can think about it as a frequency selective fat suppression to detect bulk fat, and then I'll talk a little bit about signal loss on in and out of phase imaging that looks at intravoxel fat. It's important to keep in mind that when you're looking at opposed phase imaging, chemical shift imaging, when you look at in and out of phase imaging, you're detecting intravoxel fat and not bulk fat. So let's look at an example here. In the right kidney, there's a T1 hyperintense lesion on in-phase image that does not drop out on out-of-phase image, but on a frequency selective fat suppression, you lose signal. So this lesion loses signal just like the bulk fat in the subcutaneous tissues. This is a fat-containing lesion and an angiomyolipoma. On out-of-phase imaging, what you see is this India ink artifact. This voxel contains water and fat, so it loses signal on out-of-phase imaging. So this lesion contains fat, and adjacent kidney contains water. So voxel has contribution from fat and water and loses signal. So let's look at this. The case here, on a non-contrast CT, there is no bulk fat. On a post-contrast CT, this lesion enhances. So this is an enhancing renal mass. And at this point, it's hard to know if this is a cancer or a lipid-poor angiomyolipoma. There are a couple of clues that we can think about. This is slightly hyperdense, has a similar density to the muscle, smooth muscle, and has a homogeneous enhancement. If in the right age of patient, and this could, at least you should suggest a possibility that this could be a lipid-poor angiomyolipoma. Because as Isaac showed earlier, this is very easy to do a biopsy in these lesions and actually make a confident diagnosis on biopsy of a lipid-poor angiomyolipoma. And so if you do that, you avoid surgery in these patients. Can MR help in these cases? So again, this is the in-phase image and an out-of-phase image. Is a lesion in the right kidney that loses signal on out-of-phase image. However, there is no India ink artifact. This lesion does not contain bulk fat. Is this enough to make a diagnosis of angiomyolipoma? And the answer is no. You need a bulk fat to make a diagnosis of angiomyolipoma. So if you look at this lesion on T2 image, you see it's heterogeneous and has heterogeneous enhancement. The T2 characteristics and the post-contrast characteristics are not compatible with the diagnosis of an angiomyolipoma. This was a renal cell cancer. So both can demonstrate loss of signal on opposed phase imaging. Studies have shown that it is a higher loss of signal intensity in lipid-poor angiomyolipoma compared to RCC, but there's no real cutoff that can confidently make you differentiate between these two entities just based on signal loss. So you can look for other features. So angiomyolipoma, or myolipoma because they don't have lipid, and a more smooth muscle, they tend to be homogeneous. They tend to be homogeneous on T1, it has to be homogeneous and hypointense on T2 with homogeneous enhancement. They usually, if they don't contain hemorrhage and they don't contain calcification. So presence of necrosis, presence of hemorrhage, calcification, heterogeneity on T2, heterogeneity on T1, that should suggest a diagnosis of a renal cell cancer rather than lipid-poor angioma lipoma. What about oncocytoma versus chromophobe? Well, I mean, I can tell you that I don't remember anymore which one is which because they both look the same. It's really hard to differentiate these two entities based on imaging. There are overlapping imaging features. You can see central scar on both. Segmental inversion has been reported with both. And sometimes on biopsy, it may be difficult to differentiate between these two entities. There are advanced tools like diffusion and perfusion imaging that have shown some promise, but morphologic imaging is limited in differentiating these two entities. So once you decide that this is not a benign lesion, it's not a lipid-poor angioma lipoma, and it looks like renal cell cancer, then the goal is to actually differentiate between different types of aggressive kidney cancer. There are three most common types of kidney cancers that we'll talk about. One is a clear cell renal cell cancer, which is the most common type of kidney cancer, and the other two are papillary subtype of kidney cancer and chromophobe subtype of kidney cancer. Clear cell renal cell cancer is more lethal or more aggressive compared to papillary and chromophobe subtypes of kidney cancer. And this is an old study, but what they showed here was that there was a lower cancer-specific survival in clear cell cancer compared to papillary and chromophobe cancer. So if we can accurately diagnose the patient as having a papillary subtype of kidney cancer, for example, maybe in patient who has other risk factors for surgery may not go to surgery. Maybe they'll go to a local regional therapy. Maybe they'll go to ablation, maybe surveillance protocol. So our surgeons actually are very interested, or urologists are very interested in patients who are not a good surgical candidate for us to tell them how concerned are we that this tumor is a clear cell cancer versus a papillary or chromophobe subtype of kidney cancer. CT can be helpful to differentiate between these subtypes. So here, this was a study from 2013 that showed that the papillary subtype of kidney cancer has a lower enhancement on a corticomedullary and nephrographic phase compared to clear cell renal cell cancer. But there's some overlap with oncocytoma and chromophobe. So the papillary subtype of kidney cancer tends to be hypointense, hypovascular on a post-contrast imaging compared to clear cell subtype of kidney cancer. Let's look at this on MR a little bit. So if you look at MR, this right lesion here, this is a avidly enhancing lesion. And so this is a heterogeneously enhancing lesion. This is more suspicious for a clear cell subtype of kidney cancer rather than papillary subtype of kidney cancer. And the reason for that is that in clear cell cancer, there's an abnormality in the HIF pathway that causes neoangiogenesis. And so you get hypervascularity. And you compare that to a papillary subtype of kidney cancer, they tend to be T1 hyperintense sometimes on a pre-contrast images, and they have a really low level enhancement. So if the lesion is more homogeneous, T1 hyperintense with low level of enhancement, that is going to be a papillary subtype of kidney cancer. So the next question is, how good are we at differentiating this? I forgot to mention that on diffusion imaging, papillary subtype of kidney cancer tends to have a lower ADC compared to other subtypes of kidney cancer. And so the question is, how good are we? And so this was a meta-analysis published last year, and basically what they did was they looked at T1 signal, T2 signal, and enhancement. And they found that based on those features, you could differentiate, you can diagnose a papillary subtype of kidney cancer with over 90%, or really 90% accuracy. And so idea is that if you actually can do that well and confidently, then maybe you can characterize them as being more indolent compared to other subtypes of kidney cancer. And again, this was a meta-analysis where they did not include diffusion imaging data, because not all studies had diffusion done with the same B values and so on, so they excluded the studies with diffusion imaging. And the idea here is that if you actually include diffusion imaging, you will further improve your accuracy in characterizing lesions as papillary subtype of kidney cancer. And just a little data from our group a while ago. Basically what we did here was we did diffusion imaging with multiple B values. So we did a low B value used to calculate so-called perfusion fraction and a high B value to calculate true diffusion coefficient, or DT. And then we also looked at heterogeneity of these lesions. So what we see here is that, for example, you can differentiate between the papillary subtype of kidney cancers have a low perfusion, whereas the clear cell, chromophobe, and those lesions have high perfusion fraction. But they also have the papillary subtype of kidney cancer also has a low DT. So based on FP and DT, you can actually try characterizing these lesions well. And as you can see here, some of them overlap. But if you look at the heterogeneity in these lesions, you see that angioma lipoma tend to be more homogeneous. Oncocytoma actually at imaging and at histopathology tend to be heterogeneous tumors. And so you can actually start differentiating angioma, and oncocytoma from a clear cell and chromophobe subtype of kidney cancer. So this kind of analysis will allow you actually to have a further appropriate characterization of these lesions as being indolent or aggressive. So in conclusion, our role as a radiologist to diagnose and stage renal masses, provide preoperative planning, but on top of that, as we do a more targeted therapy and a patient-specific individualized therapy, non-invasive assessment of tumor aggressiveness is going to play a bigger and bigger role. So thank you very much for your time.